So I'd like to welcome everyone to the Mixed Methods webinar series taking place today on April 12th, brought to you by IIQM as well as the Mixed Methods International Research Association. And today's webinar is brought to you by the Seniors Research Innovation Seniors Care Research Unit. And so we're going to have a special host for today, Wendy Duggleby. So Wendy, you can go ahead.
Oh, good. Thanks so much, Yvette, and welcome everyone. It is a great deal of pleasure that I introduce our speaker, but first I'm just going to give you a bit of an outline. I think Dr. Ploeg is going to speak for about 30 to 40 minutes, and then we'll do questions. And because there's so many people online, which is just wonderful, if you could please put your questions in the chat, and then that way we'll use those when in our discussion sessions. So I'm just going to go ahead and start. Was there anything else, Yvette, I needed to mention?
No, everyone will stay muted until the end, and at the end, if you did want to give people the microphone, if they want to ask questions themselves, there's also that option.
Okay, thank you, and thanks so much for setting this up. So it is a great deal of pleasure that I introduce our speaker today. Dr. Jenny Ploeg is a professor in the School of Nursing, Faculty of Health Sciences, and associate member in the Department of Health, Aging, and Society, McMaster University in Hamilton. She has an extensive history of peer-reviewed grants and publications. Actually, she's very prolific and very well funded, and always an envy to the rest of us. Her program research is focused on two key areas: evaluation of health services for at-risk older adults and their family caregivers living in the community, and evaluation of best practice guidelines, implementation, sustainability, and spread, which will be our topic today. Along with Dr. Maureen Marco-Reed, she is co-director of the Aging Community and Health Research Unit, funded by the Canadian Institutes of Health Research Signature Initiative in Community-Based Primary Health Care and the Ontario Ministry of Health and Long-Term Care Health Systems Research Fund. This research unit is focused on the development and evaluation of innovative interventions, and she does a tremendous amount in terms of building research capacity in this area and mentoring of students. And I must say, I have the pleasure of working with Jenny, and she's just a wonderful mentor and a wonderful person. So I think you'll enjoy today her presentation on spread and scaling up of research. So I'll hand it over to you now, Jenny.
Thank you very much, Wendy. It's really a joy to be here with all of you today and to have this opportunity to talk about this research. So thanks for coming. And please feel free, as Wendy said, to add any questions as we go along. And I'll try and make sure that we have some time at the end. So as Wendy said, I've been interested in the whole area of best practices, both implementation of best practices, evaluation, spread, sustainability for a number of years, and worked extensively with people like Nancy Edwards and Barbara Davies, as well as the Registered Nurses Association of Ontario. And so it's really a joy to talk to you today about the work that we're doing in this area. So I'd like to acknowledge the research team on this particular project, and that included Maureen Marco-Reed as my co-PI, as well as Barb Davies, Catherine Taguchi, and Wendy Gifford from University of Ottawa, and Irma Jean Baynock and Heather McConnell from the Registered Nurses Association of Ontario. So for those of you who are interested in more information about this study, it has been published in Implementation Science, and it has quite a bit of detail in there that we won't be getting into today. So I thought today what we do is talk about a few different areas. So first I'd like to talk a little bit about why is it important to study sustainability and spread of innovations. Then I'll briefly try and describe some of the results of this particular grounded theory that studied sustainability and spread of best practices. And then at the end, I'd really like to talk about some of the methodological challenges that we faced in conducting this study and some of the strategies that we used to try to overcome those. So particularly for this more qualitative methods kind of audience, I thought that latter objective might be of quite some interest to you. So spread has been defined in various ways, and many people use the terms spread and scale up interchangeably, but often scale up is used more in the developing country kind of side, where we're talking about immunization programs, child health programs, and spread has been probably used a bit more in developed countries. So Buchanan and his colleagues described spread as the process through which new working methods developed in one setting are adopted, perhaps with appropriate modifications, in other organizational contexts. So that's the definition of spread that I used in this study. So why is it even important to study spread? We know that innovations that start out in one small area or one small unit, if we can spread those innovations so that they're actually used in other areas as well, it really helps promote efficient use of scarce resources. We know that spreading best practices in healthcare really involves some time-consuming, complex, and resource-intensive processes. And further, we know that a lot of implementation, sustainability, and spread efforts fail over time. So we've seen that a lot with some of our guideline work with the RNAO, in that many times organizations spend a lot of time and energy and effort trying to get a new guideline, a new practice going in practice, and it seems to work for a little while, but then it just drops off the scale. And it's really discouraging, not only for those who try and get that new practice going, but for those who have made so much time and energy and effort in trying to keep it going. So then we've also noticed that nurses and other professionals become discouraged and are not as likely to try new approaches again in the future. So it really is an important area to study. We also know that there's not a lot of research on the process of spread, the factors that influence spread, or the models of spread. And that really led to this particular study. We decided to study spread in community-based home care organizations. So certainly, as Wendy's interest is also with older adults, so is ours. The population of older adults is certainly growing, but those who are users of home care services are predominantly older adults. These older adults are often very vulnerable. They have a lot of multiple chronic conditions and complex care needs, so it's an important area to study. The work environment itself is very unique and also important to study. The staff are usually geographically distributed over wide areas. There are limited budgets and heavy workloads in home care, and there are very high turnover rates of both staff and managers in home care. So in addition to our prior work with home care and our commitment to community-based care for older adults, this led us to really focus on the issue of spread in these organizations. So the purpose of this particular study was to develop an understanding of how best practices related to older adults are spread within home care agencies. So we had two questions. What is the process that's used to spread best practices related to caring for older adults within home care agencies? And what factors influence spread or non-spread? So in this particular study, we used a qualitative grounded theory design based on the work of Strauss and Corbin, and we sampled 4 different home care agencies in Ontario. And those agencies had implemented a best practice guideline related to care of older adults, and they had to either have already spread, were in the process of spreading, or plan to spread that guideline within their agency. So this slide basically summarizes these organizations that we worked with. 3 of them were actually home care provider agencies where their staff provided care to patients, and 1 was a provider agency where they contracted out services to other organizations. So these organizations provided care annually to anywhere from 65 to 120,000 clients per year. So these are relatively large organizations. Most of them have more than 1 site. So many of them have diverse branches or sites that they work from. They also have different types of employees. Most of them involve nurses. Many of them involve healthcare aides or PSWs, as well as therapists. We were also really interested in looking at different guidelines. So we looked at assessment and management of pain, venous ulcers, and falls. So we had quite a diversity of the kinds of innovations that were implemented in these organizations. In terms of data collection, we did in-depth semi-structured interviews. We plan to do about 8 to 12 per site for each of the 4 sites and include frontline providers, managers, as well as directors. And we plan to do it both at baseline and 1 year later, recognizing that the process of spread is often a longitudinal one, and so we really wanted to try and capture that over time. We completed 84 interviews with 46 participants, 44 at baseline and 40 1 year later, so approximately 10 per site. And myself and one of the research coordinators conducted those interviews. So at the first time point, we asked questions that really got at their experiences with the spread process, their roles in the spread process, what they thought the process of spread was, the facilitators and barriers to spread, and then again, really wonderful opportunity at time 2 to talk about what has changed, what's happened in the year between then and now in terms of the spread process. What things are still happening? What kinds of activities have you been involved with? So that was a really unique opportunity. In terms of methods, our data analysis involved certainly transcribing the interviews, but then using open, axial, and selective coding as per the grounded theory approach. We developed flowcharts representing both internal and external spread activities for each of the 4 different sites. We used constant comparison, where we compared not only across the sites, but within sites in terms of different groups of participants. And we also used member checking. In terms of who were the participants in our study, you'll see that the majority were 40 years of age and older, so this was an older home care group. 41% were frontline staff, 26% were managers, 17% were resource staff, i.e. consultants on wound care or other kinds of roles, and then 15% were senior managers. In terms of working status, the majority, 80%, worked full-time. Most of them had backgrounds in the area of nursing, but not all of them. The mean length of time that they worked in their current position was 6.3 years, and at their current organization was 8.8 years. So that gives you some sense of who these participants were. We came up with a model of spread in best practices in home care, and this was the model that we finally landed on. And I'll talk a little bit later about the process of getting to this point. So you'll see these round balls in the center basically represent the different phases or stages of the spread process. So it started with committing to change, and it moved on to implementing on a small scale, adapting locally, spreading internally to multiple users and sites, and then disseminating externally. On the right-hand side, you'll see facilitators, and those were the main facilitators of this process, and those included at the top seeing the benefits at multiple levels of the client, the provider, the system, the organization, sustaining strategies, and leading with passion and commitment, and I'll talk about each of those. And this all happened in the bottom, the little arrow at the bottom, within this context of home care, which I'll describe a little bit later. So I'll talk briefly about each of these phases, as well as some of the facilitators, and then we'll get on to some of the methods issues. So the first phase was committing to change. And within the organizations, all of these organizations had an association with the Provincial Nursing Association, the RNAO, and so they were what is called best practice spotlight organizations. So they had committed to actually implementing, evaluating, and spreading best practice guidelines within their organization. So there was already a commitment to really focus on evidence-informed practice. There was also a commitment that involved allocation of resources. So there was funding through the RNAO for a dedicated project leader and some targeted education and supplies. Furthermore, there was a recognition of a gap in service or a gap in care. And that gap, the the high-level managers in the organization were very committed to addressing that gap. The second phase involved implementing on a small scale. And so there were 3 organizations that actually did spread internally, and 1 did not. For the 3 that did spread internally, they had a steering committee that guided that spread process. They had dedicated project leads, champions, and managers, all very committed and working together to develop a spread process that would work. Those individuals and groups reviewed the best practice guideline. They would identify some key practice recommendations that they felt were reasonable or feasible. They developed practice tools based on those recommendations, and then they helped to plan the processes to spread those new practices. The third phase of the spread process was adapting locally. So they would try it out on a small scale, and then the project leads, champions, managers, and steering committees reflected on the feedback. They adapted the innovation and the spread process to better fit the specific context of the sites. So in some cases, the innovation might have involved a tool, for example, to assess and intervene in the issue of pain among older adults with home care. And so some early feedback from some of the sites were that this was too resource intensive, it was too much of a burden on clients and families, and it needed to be changed. It needed to be more simple, more easy to use, more feasible. And so that was what was happening at this level. So then the next phase was spreading internally. Once those changes had been made, moving that innovation to multiple sites and users. This was usually a phased approach. So those organizations that might have had 10 different sites or 10 different branches, they would phase and start, okay, these 2 sites we're going to spread in the next 2 months, then the next 2 in the following 2 months, and so on. So it was a very strategic, phased approach to spread. 3 of the 4 organizations demonstrated internal spread, but none demonstrated external spread, where that innovation, that tool, those processes were actually adopted by external organizations. And I'll talk a little bit more about why after. So the last phase, instead of being called spreading externally, was called disseminating externally, because participants did share their experiences through presentations, at conferences, through articles, and through many of their connections. So they did share their experiences, but we didn't actually see an uptake of those new tools and processes by external organizations. So in terms of the model then, on the right-hand side were these 3 facilitators for this spread process. And I'll talk very briefly about each of those processes. So the first was seeing the benefits. And seeing the benefits created an ongoing momentum for the spread process. So participants acknowledged the power of rapidly seeing benefits for clients and its impact on providers. And seeing the benefits of the change for their own practice was often also as important as seeing the benefits for clients. In some cases, they actually saw benefits at a higher system level. I'll intersperse a few quotes. This is what one person said. I think what makes this one easy to spread is the fact that very quickly the nurses realize how much they can improve the disease experience for their patients. So they really help buy in because they feel empowered to make a difference. And pain is such a distressing symptom that to walk away from that visit and know you've made a difference is really a powerful thing. So in some of these situations, there was a quick benefit, a quick win, and that really helped facilitate the spread process because they would tell stories about those changes. They would tell stories about, Mrs. Jones, we saw this happening, and it was really powerful. The second facilitator was leading with passion and commitment, and this really involved the leadership approach of 4 groups of individuals: the project leads, the champions, the managers, and steering committees. And so this slide tells you a little bit about the different roles of those individuals within the organization. And so the project leads were sometimes managers or resource staff who had protected time to take on responsibility for the spread. The champions were individuals at all levels of the organization, frontline managers, administrators, who were passionate about the innovation, and they acted as go-to people. So other people would say, I always go to Charmaine because she knows how to use this new tool. She knows a lot about this process. The managers were often very key because they would go on joint home visits and provide guidance and support for nurses and others about how to use these new tools. And then the steering committees really were the ones that developed the tools. They helped guide the education processes. They helped with the evaluation, and they revised a lot of the tools and processes. This is a quote that's, again, powerful just because she was persistent. And when you have a vision, you share it with other people, you're passionate about something, they tend to feel your passion too. So I think that was probably the biggest driving force that contributed to her success with it. She just created all of these followers. And so that happened at a number of different sites. The third facilitating factor was these sustaining strategies. So these 4 strategies really helped to sustain the continued use of the innovation once spread had occurred. Engaging and communicating, educating and coaching, integrating it into practice and policy, and evaluating and giving feedback to the people who are actually using it. We really started with a focus on spread, and we're continually faced with this issue of sustainability that was so intertwined with the spread process. So you could spread something, but if it wasn't sustained, again, it was seen as a wasted effort. So I'll talk a bit more about that after. One quote was, "So it's never finished, it's a cyclical thing. We just have to keep going with it to sustain it, to make sure that people continue to use it and continue to learn, continue to try and find a way to reduce the number of injuries, if not the number of falls." So this was a site that focused on fall prevention. This all happened within the contextual framework of home care. And this home care context in Ontario is just riddled with barriers to the spread process. At an individual level, there's resistance to integrate new practices, particularly given the heavy workloads of staff already and the high documentation requirements. At an organizational level, there's huge levels of staff and manager turnover. There's also a lack of electronic records, so it makes it really hard to do any kind of assessment of the impact of these changes. At a systemic level, this is a very large and decentralized workforce that seldom gets together for meetings or interactions with each other. And in Ontario, there's also a system of what is called managed competition, where these different organizations actually compete for contracts for home care. So all of those factors really created some barriers to the spread. So in terms of a few implications of the findings, certainly we found that there's a need to make some critical investments in resources, i.e. the leaders or the champions, the communication and education efforts. The integration of strategies for sustainability should be at the very start of the spread process. I'm sorry, a few of these slides are a little bit mixed up at the bottom, and so I'm sure it's just a formatting issue of entering it into Adobe Connect. There was also a lot of implications to ensure that efficient and audit and feedback mechanisms so that people could see the benefits of spread. If people are implementing a new innovation related to falls prevention, but they really don't have a sense of is it making any difference to falls rates, that has a huge implication for ongoing spread and willingness to change. Certainly in this home care environment, the need for technical support, electronic health records, and evaluation expertise was key, as well as the importance of considering contextual factors. So if you don't recognize that managers and staff are very likely to turn over in high numbers, and that you have strategies in place to continue to increase their involvement, engagement, and passion for this change, then you'll be in trouble. So the next part of my presentation, and I am planning on finishing in about 5 or 6, 7 minutes, the next part I really would like to focus on some of the methodological challenges and the strategies. So I'd like to focus on 5 real challenges that we faced in conducting the study that I think would be of interest to you. So first of all, choosing sites to best capture spread. Secondly, deciding when to collect data on spread. Third, using negative cases to enrich findings. Fourth, developing a model of spread. And 5, considering the context. So I'm going to frame each of these as the challenge and then some of the strategies. So this challenge was, how do you identify home care sites that had implemented best practices related to older adults and planned to or had spread? And how do you capture diversity in home care sites, i.e. different guidelines? So here is what we did. We worked with our Provincial Nursing Association, the RNEO, who really had closely tracked many of these organizations because they were involved in the BPSO program, the Best Practice Spotlight Organization program. So working with them, they helped us to identify which home care sites had implemented which best practice guidelines related to older adults. So we had a kind of a sampling frame to begin with. We then obtained information from the sites regarding where they were at with implementing those guidelines and where they were at regarding stage of spread. We then selected some of those sites that seemed to best meet our criteria for our study, and we met with their representatives to talk about what is happening in your site regarding implementation of the guideline and spread and how it fits with the study goals. Is this something that you would be interested in? Does it seem to fit with our study goals? And together we made some decisions about which sites would be the best, and in some sites that were implementing multiple guidelines, which guideline would be the best one to focus on in that site. Another challenge was deciding when to collect data on spread. How to avoid assessing spread too early. If you do that too early, there's not enough information to really make an informed decision about what that theory or framework of spread should be, or too late, and then you deal with recall issues. And how to assess the process over time in terms of looking at longitudinal data. So our strategies, we really, as a team, had done quite a lot of research in terms of sustainability of best practice guidelines, as well as implementation. And so that understanding helped us to kind of get a sense of when would be a good time after guidelines had started to be implemented to start thinking about the spread process. We also collected data at both baseline and 1 year later, and that really permitted an assessment of those changes over that 1 year period. And there are pros and cons, because some would argue, is that really long enough? Some would argue maybe you needed another time a year later to see if it was actually sustained after having been spread to those different sites. And so it's always dependent on the resources that you have in a research study. So this was certainly better than doing a cross-sectional assessment, having 2 time points. And we certainly did get a lot of rich data from having done that. We did include sites that were both early on and later on in the spread process. So one of the sites was only starting to think about spreading the guideline. In another site, they had already done it and were well underway for more than a year. And so when we started baseline, so we had some variation in that I think was helpful in helping us to understand. The third challenge was negative cases. How to deal with the disappointment that one of your 4 sites simply did not spread. And again, as researchers, you always think, well, it would be ideal if we had 4 sites that had spread, because we could learn a lot of lessons about what the nature of a theory of spread or a model of spread would look like from those 4 sites. And then to learn that one site simply didn't even spread was really quite a big disappointment to the research team. Then we had to move to how do you use a negative case to contribute to the theory and the model development, and then how to reconcile differing viewpoints of frontline staff and managers, because we found that in some cases frontline staff would indicate this really is not being taken up as it should have been. We are not using it to the extent that we should, and managers would say, yes, we're using it well in our organization. So some of the strategies, certainly we compared the similarities and differences between the positive and the negative case of spread. We looked at things such as the processes and the facilitators, and I'll talk about that in a moment. We collected data from different perspectives, frontline as well as managers. And we used theoretical sampling. In the one case that hadn't spread, we kept hearing from the managers, yes, spread has happened, but the frontline, the few that we had interviewed, would say, no, we're really not using it. So we knew that we had to interview more frontline people to really get a better sense of what was actually happening in that situation. We also learned to really value the negative cases as important sources of data to enrich the findings and the theory. So when we did a comparison, this shows two main themes. So the leading with passion and commitment, where you have the active engagement of project leads, champions, managers, and steering committees. Those were all present in the 3 positive cases. In terms of sustaining strategies, educating and coaching, integrating the innovation into practice, engaging and communicating, evaluating and feedback, those were all present in the positive cases. And then when we looked at the negative cases, it was really quite shocking to see that those facilitators were really not in evidence at all in that negative case, or to such a minimal degree. So what this does then is it really confirms, wow, we must have been on the right track with identifying these as the key facilitators of spread, because in the non-spread case, none of those were actually present, or to a very minimal degree. So it is really important to reshape how we look at our research findings and value the negative. In this case, this was the most outstanding negative case and the most valuable for me in my research career, because it really confirmed we're on the right track with understanding these facilitators of spread. Another challenge was developing a model of spread. How do you integrate site similarities and differences in a visual model? How do you balance simplicity versus complexity of a model? How do you consider differing views of team members, of research team members, related to the visual depiction of the model? And how do you ensure that the model holds true to the data and to the site experiences? So some of the strategies that we used was we started with developing flowcharts for each agency of their internal and external spread processes, and we looked for similarities across those flowcharts. We identified antecedents, spread strategies and processes, benefits, facilitators, and barriers to spread across all of the Time 1 interviews. We developed some sheets that summarized those, and at the Time 2 interviews, we presented those to each of the participants and said, here's a list of facilitators that we came up with at Time 1. Which ones were most important to your spread process? And we got a lot of rich feedback about what their perceptions were, again, demonstrating the value of the 2-time data collection. This is one example of a flow chart, and you'll see at the top it kind of talks about some of the areas of expansion. So in this case, it was 1 branch, 4 sites over 1 to 2 months. It talks about who were involved, the consultants, talks a little bit about the documentation and policy, the education, the communication and support that happened, orientation, and then evaluation and feedback. So we developed these both internally, and the next one is for external, spread or dissemination for each site. And then we looked carefully at these data across the sites, and we also kept going back and forth to the original data itself. And it was this process that really helped us get a sense of the different processes of spread across sites. We developed many different versions of the model. We discussed the findings in the model with the team. We kept returning to the data to confirm the model. We did Google searches for images of models. We met with study sites and we shared the model and got a lot of rich feedback. And we were very blessed to be able to hire a tech company to help develop a visual of the model. So this is one of our first versions of the model. And you'll see it's quite linear. And it certainly has some of the components that we had in our final model, but you can see that we're struggling with how to put these ideas into a picture that really demonstrates what this spread process is like. We moved from that into one that was a little bit more interactive, a little bit more perhaps engaging and demonstrating the interaction between the various components, but again, still quite linear in nature. And then we got way too complex. I'm sure everybody is laughing at this one. I'm sorry I can't hear your chuckles of laughter right now, but this was really quite complex. Like, we included everything here, didn't we? We have antecedents, we have implementing on a small scale, we have all of the providers here, we have all of the details about leading with passion, we've got all the different contexts, and it is overwhelming. So what happened somewhere in the process, and it was probably somewhere around there, is we recognized that the phases of spread are complex and they reflect a number of process characteristics. So they reflect sequences, So there were certainly sequential movements through the phases. The process of spread also reflects cycles or cyclical processes where, for example, you educate staff, they try it out, they give feedback, and then you revise. So that kind of cyclical nature. But there are also spirals where the spread activities gain momentum and accelerated over time. So we really moved to more of a visual that looked like this. Again, this one was a little bit complex. The illustrations at the right-hand side were not as flexible as we thought we would like, and so this was the final model. And so you'll see that it kind of demonstrates that the facilitators on the right-hand side are intertwining through kind of a rope system through all of these phases, that the phases increase in size and momentum as we go through, and that some of these arrows back and forth are trying to demonstrate that there's a cyclical nature. So this was quite a challenge. It was also a great joy to work through that. The final challenge was considering context. And how do you encourage participants to consider contextual factors that are influencing spread? And how to facilitate honest reflection of sensitive topics, i.e., how the competition with other agencies might influence spread. Because we actually did have people who said, we're in competition with them, we will not be likely to share our new tool, our resources with those organizations, because we're in competition with them for a contract for home care. So we really considered and reflected on our own team's experience with home care. Many of us had practiced in home care, had done research in home care, and we really carefully considered that. We reviewed the data carefully for indications of contextual factors, and again, having this wonderful opportunity at time 2 to add probing questions. What were some of the barriers and facilitators to sharing information? So we really targeted some of the questions much more delicately perhaps, but much more strategically at time 2 to get a sense of that. And we also reviewed policy documents and the literature around that. So in summary, we really learned a large number of lessons in conducting this research study. One of the important lessons is to use a wide variety of strategies to study spread. Longitudinal data certainly is ideal when you're looking at a process that changes over time. To integrate feedback from multiple viewpoints often. So we went back to our participants at time 2. We also went back to the sites with our draft model, and we got some rich feedback from them. Avoid settling on a model too early, and to continue to explore options. The more feedback you get, the better, the richer it can be. To value the negative cases as rich information sources, and to enjoy the journey. So I think that's a quick and dirty summary of the study and some of the methods challenges that we faced and tried to address. So I'm going to turn it over to Wendy to engage the audience. Thank you.
Jenny, thanks so very much. I really appreciated your presentation, and I've got some questions myself. However, I'm going to go to the audience. We have one from Annie Vandermouse. Annie, do you want to just take the microphone and ask your question? Annie, for some reason, it wasn't coming through. So I know you sent it on a chat. So I'll go ahead and ask it. Her question was, Jenny, how did you manage communication with a negative case agencies, since the lack of spread and differences in opinions within the site would be politically tense? It's very similar to one of the points you made. So if you could just talk more about how you manage that.
Mm-hmm. That one was a really challenging one, especially at time 2, and we had great difficulty even getting appointments for follow-up interviews at time 2, probably because they were very sensitive about their lack of progress on that area. But again, in some of these organizations, we did have a previous relationship with the organization. We had done research with them. to some extent, this was not surprising. And so we certainly framed it as, it is very challenging, this home care environment, in terms of a lot of changeover of staff and managers, and that had happened at that organization. They had initially had a project lead who went on an early and unexpected maternity leave, and that person was not replaced. So it is continuing to reflect back to them how challenging this process of not only implementing guidelines but trying to spread guidelines is, and recognizing the challenges that home care organizations face. So again, it is really challenging because they were obviously disappointed too. But it's trying to frame it within an understanding that, it's a really challenging work environment. And we know that you're doing the best that you can. And there are lessons learned from this that we hope will be valuable to you. So does that kind of answer your question, Annie?
Thanks, Jenny. I think there's a couple more that I'm just going to ask you. One was from Ahmad. For the transcription of the interviews, how did you try to avoid any bias?
I'm not sure of the question, I guess. Wendy, do you know what the question is? So these interviews were audio taped and transcribed. So we had somebody external to the research unit do the transcription, certainly. So when the transcriptions came back, internally we would clean the results. So in that sense, the data is the data. I guess it's probably perhaps more of a question about how to avoid bias in analysis or interpretation. So maybe I'll just talk about that for a moment. We certainly spent a lot of time and energy going through these 84 interviews. So these were generally about an hour in length. Some of the staff ones were a bit shorter, but there was a huge amount of data. And so what really helped, I believe, is going back to our research team frequently, but also going back to the participants. So when we, after time one, had developed a list of, for example, some of the themes in facilitators, we took that list back to the participants and we said, this is a list of some of the facilitators that all of the sites identified. Which are most important for you at your site? And it was quite surprising that most people said all of these were important at our site. And so often people would say, this one I think was more important in our site, but there was a sense that the interpretation of the findings was connecting with the participants at the sites. So that was a really positive process in terms of trying to avoid bias in interpretation of results.
Oh, thanks so much, Jenny. And there was a chat from Annie that the previous question, and she said, thanks very much for answering the question. It sounds like feedback to the group is useful as well. And from this latest question, Ahmed, he said, I got the point, thank you. So that's great. And there's another one here from Donna Allen, and she doesn't have a mic, so I'm just going to read her question. She asked, could you speak a bit more about the process you decided about how long is too long or when is too soon? She plans on doing research with family members with dementia and their communication with them, and she's trying to determine the best timing between early signs of Alzheimer's and too far advanced.
That's a great question, and probably Wendy is even better suited to answer that, but I'll try. Wendy has done so much research in the area. We're actually doing with Wendy, and Wendy's the lead on this study right now, a study on use of a transition toolkit with caregivers of older adults with dementia. And we're doing a number of different studies in ACRU, but this one in particular, we're seeing a number of people are unable to complete the study because of increased demands as a caregiver, and people moving into long-term care homes. And so that's quite different than one of our previous studies that dealt more with older adults who had diabetes and multiple chronic conditions. So I think you raise a really important question here about, you know, the timing of these kinds of issues. And so I would say for dealing with dementia, if it's the early phase, you may still see that you can't wait a year, for example, to do a follow-up interview. Probably, you know, even 3 to 6 months might be a better timeline. For this particular study, when we're dealing more with processes that are internal to organizations, the timing probably of a year was quite a good selection point. And that was partly based on our previous work with implementing and evaluating best practice guidelines. And we actually saw in one of our previous studies that sometimes at a 2-year point after an initial implementation of guidelines, only about, for example, 25%. I'm not sure on the numbers and percentage, but only 25% were still sustained. But if we went to 3 years instead of 2 years, the number actually increased. So that we saw that it often took time before new innovations, new ways of working, new processes of working were actually integrated into the organizational structure. So it is possible that 1 year was not long enough. It's possible that if we were going back to the non-spread site a year later, that things might have looked different, that maybe they were actually successful at that point in time. So I think your whole question about how long is too long and when is too soon is really important, because it really does the quality of the data that you get. And Wendy, maybe you can speak to that more about dementia.
Yeah, I think, Jenny, thanks for your good points. I just want to add one thing. To me, it also depends on the complexity of what you're spreading. So there's some I think that are readily, and the only way I think you know, and I think, Jenny, you're speaking from a great deal of experience, is to try it.
Yes.
Because I don't think there's any hard and fast rules, and with each different population, you're starting to get a different sense, and it depends on very much their situation too, doesn't it, Jenny?
That's right.
What they're doing. So here's the next one, Jenny. Did you set out with the intention of creating a visual model of spread, or did that idea develop through the analysis process?
That's a really good question. I would say it developed over time. Certainly we came at it with a plan to develop a theory of spread. And so many theories do have associated models or visual illustrations of those theories, of the main concepts, for example, or conditions or outcomes. So I think it was probably a little bit in the back of our head, but to understand the number of different versions of the model that we went through and the complexity of that process, we had no idea when we started it. I'll be totally honest. It was only because we had some funding that we were able to hire a company that would help us create a visual that would reflect what we were thinking. Because most of us don't have that kind of training to be able to come up with those kinds of visuals. And as you saw, we certainly started with a far more linear, far more kind of simplistic model. And then we really had to hold ourselves back and getting way too complex. A model that was, you know, simply wouldn't have been usable, would have made people really challenged to even look at it. So I'd be interested in any of you who are on the line today. Please send me an email. Let me know what you think about the model. Let me know, would you change the model? And if you would, how? Because that's an ongoing learning for all of us in terms of, you know, different people looking at different things, recognizing different things in it. The nice part was when we went to one of the sites, and I'm looking at the published paper, when we went to one of the sites, the woman, let me just find this, one participant said, "This feels familiar to me. It's exciting to see something put into the model that reflects what we did." That was a really rewarding comment, that the agency representatives recognized the truth in the visual model. So that was really rewarding for us.
Thanks, Jenny. There's a question here from Lisa Garland Baird, who you know, right?
Yeah.
And she asks a pragmatic question. For a research project of this size and length, how many researchers, grad students, trainees, and research coordinators, etc., were involved or need to be involved?
That's a good question. We had 3 years to do the study, and we had funding for 1 research coordinator, and we had a student who helped a little bit, but it was mostly ourselves. So I'll have to say I invested a lot of time and energy in actually going out on many of the interviews with the research coordinator, and that I think contributed to my deep understanding of the results. And but not all of us can do that, and not all of us can do that in every study. So that was a high level of commitment that I, as a PI, made to that particular study. And you know, certainly other researchers, Maureen as the co-PI, worked intensively with me to come up with a model and continue to challenge us in coming up with one that, you know, kind of met what we both thought really it should look like. And so it is a really challenging process. I think this study, we only had $200,000 for this study, but we did have 3 years to do it. And so it did involve a lot of time and energy from the researcher's perspective in terms of analysis of the data.
Thanks, Jenny. You're getting some nice comments here, but well, I'll send them to you later. Here's another question. This one is from Cheryl. Cheryl, do you want to ask that question? Is your mic working, or would you like me to read it? Oh, her mic isn't working. Okay, I'll go ahead. Social ecological systems, like home care agencies, tend to exhibit qualities of resiliency with respect to sustainability of changes. Is the concept of resiliency one that you've examined? What are your thoughts about how to address the tendency towards resiliency as a barrier?
I'm sorry, my phone is ringing right now, so just wait till it cuts out and then I'll try and answer that. I think that's the last ring. That's a really good question, resilience. We did not set out to examine that concept in this study. Certainly, home care in Ontario, for example, I would say has demonstrated great resilience over the past number of years, particularly in view of this managed competition and the challenges of, you know, seeking contracts and changes in organizations providing care with changes in contracts. So there has been a great level of resilience demonstrated by home care. There's also been, I think, a lot of examples of real challenges in home care. So I think most of us probably know that VON, the Victorian Order of Nurses, has changed the provinces that they're now providing care in. So they've actually had to cut back. And so, yes, they have been very resilient, but it's an ongoing moving environment, and it's really, I think, you know, quite challenging for many home care organizations to provide the level of care that they would like to, given, you know, the change in status of older adults, the clients that they're dealing with, the great turnover of both staff and managers. So I think it's, and the ongoing efforts of hospitals to discharge people who are sicker more quickly. So yes, the home care environment is very resilient, has been very resilient, but in the face of huge challenges, I think. So I think the piece where maybe resilience comes in is under the contextual analysis of this whole study. And again, some agencies probably better reflected that resilience than others. The one organization that was not spreading, really, they struggled tremendously with a lack of staffing. They had barely enough staff to go out and do home visits at times. So, you know, that really impacted their ability to take on this spread project. So I think it's a really important concept that could be home care.
Thanks very much, Jenny. Cheryl on the chat said she agrees. Resiliency can be positive and negative in the light of changes, and she thanks you for your answer. So I think you know what, I think we might have, if someone has one last burning question, there's maybe just another one coming, Jenny. She's just typing, so if we could just wait a minute. Heather, sorry, Heather, do you want to just use the mic? Have you got a mic rather than trying to type? No, okay, she stopped. Well, I think, Jenny, do you have one last words of wisdom for us before we sign off?
I think that the slide that says joy. Research is a great joy. It's always a great challenge, but it's also a great joy. And to really enjoy the time that you're developing new models, looking at data, interviewing people. It is a great joy, and it's a very rewarding experience. And so for us to, just the ability to understand this process a little bit more was a real lovely reward for us. And we had a great deal of joy working together as a team and with the agencies. I don't know if anybody's online who represented one of those agencies. We don't identify them in the paper, but they were absolutely fabulous to work with. There was such a high level of commitment and just passion for the work that they were doing. So it was a pure joy.
Very much, Jenny. And I just want to remind everybody that the slides will be up on the IIQM website, and you'll see there the reference for the paper, which does have the model in it. And I think, and Jenny's email address as well, in case you have some additional questions. So you can't see or hear us all, Jenny, but thank you so very much. It was very, Gwen Wemple said, thanks for your inspiration. So good. Many people saying thanks very much. Many thanks. So really appreciate your time and your expertise.
I really appreciated the opportunity. Thanks, everyone, for joining in.
Bye.
Bye.
Bye.